Today we will discuss the pathophysiology of the polycystic ovary. When any patient suspected to have polycystic ovary, we advise certain hormonal investigations. It has been commonly observed that serum estrogen level in many cases normal or in many cases it is higher, but most of the cases it is within the range of early follicular phase, on little higher side, because the estrogen produced by the multiple follicles. There can be a increased testosterone level, androstenedione level, which is produced from the ovary, increased DHEA and DHEAS, which is normally produced from adrenal, 17 alpha hydroxyprogesterone again from ovary, increased estrone level, which is primarily derived from the peripheral conversion of androstenedione. If you measure the LH level, almost invariably, especially in a resistant case of PCOS, it is high. It is due to increased LH pulse due to increased GnRH pulse. What are the reasons of raised basal LH level? The PCOS patients are being anovulatory most of the time. Lack of progesterone leads to a lack of opioid tone, which has got inhibitory action on GnRH neuron receptor. Second reason, the increased circulatory androgens decreases the sensitivity to estrogen and progesterone feedback. The hyperandrogenemia from any cause during fetal life, adolescence, adulthood, especially in adulthood because of the obesity or hyperinsulinemia, induces abnormalities in the feedback control of pulsatile GnRH secretion, which results in increased LH secretion. That in turn stimulates the ovarian androgen production. If you measure FSH, the FSH is either low or normal. It is because of the increased GnRH pulse. Second reason, because of the negative feedback of increased estrone production from the peripheral conversion of androstenedione. And third, there are a lot of growing multiple follicle, so increased inhibin B derived from the multiple small follicle causes low FSH. In PCOS, the insulin resistance is noted in 50 to 75% of the cases. About 35% of the PCOS cases, they have impaired glucose tolerance, and 7 to 10% of the PCOS, they have type 2 diabetes. The increased LH causes disordered follicular development, as we discussed in LH ceiling theory. The responsible feature For all pathophysiology revolves around increased LH, increased androgen, and hyperinsulinemia. The obesity contribute to it. The obesity relates primarily to genetic and environmental factors, and it is common but not the essential features of PCOS. Obesity leads to increased intra-abdominal fat, which is metabolically active. So there is more lipolysis, there are more release of free fatty acid, and it produces number of cytokines involvement in the insulin resistance. So obesity is one factor which increased insulin resistance. There is dysfunction in the signaling by inositophosphogycans, which is also important for increased insulin resistance. So, to summarize, obesity and dysfunction in signaling by inositophosphogycans is responsible for increased insulin resistance. Now, what happens because of the increased insulin resistance? The endogenous insulin is not effective in fat, muscle, and liver. So, what happens in fat? There is hydrolysis of triglycerides, which leads to elevated free fatty acid, which leads to increased androgen production, which again leads to increased insulin resistance. So it becomes a vicious cycle. What happens in the muscle? Because of the endogenous insulin is not effective, there is decreased glucose utilization in the muscle, and muscle is a major portion of the body. So there is increased blood sugar level, which again causes compensatory hyperinsulinemia. Because of the hyperinsulinemia, the insulin potentiates the action of LH, plus the insulin has got direct action on theca cell, leading to increased ovarian androgen production. When there is minimally increased ovarian androgen production, it is beneficial. But here in PCOS, there is remarkably increased ovarian androgens. So the conversion to more potent 5-alpha reduced form of androgen happens, and which cannot be aromatized to estrogen. So there is a hyperandrogenic environment in the follicle. Because these androgens cannot be aromatized to estrogen, it inhibits the aromatase activity. It inhibits the FSH induced LH receptor on granulosa cells because of the lack of estrogen. which leads to inhibition of progressive follicular development, which leads to arrest with atresia. So there are multiple follicles, they start growing but then they get arrested, which leads to increased volume of ovary. Now, because of the increased volume of the ovary, the theca cell mass is also increased. So the sensitivity to LH due to over expression of LH receptors in theca cells leads to dysregulation of steroidogenic enzymes, which again leads to increased ovarian androgens. So again, this is a vicious cycle. Because of the compensatory hyperinsulinemia, there is inhibition of sex hormone binding globulin. Because of that, there is increased circulatory androgens, which is again causing increased insulin resistance. So this is also forms the vicious cycle. Now, it has been observed that there is increased adrenal androgens like DHEA and DHEAS for the mechanism which is not known, which leads to a peripheral conversion to testosterone, which again leads to increased circulatory androgens and which is responsible for increased insulin resistance again. So in short, it is a vicious cycle which keeps happening. Because of the endogenous insulin is not effective in liver, it leads to a neoglucogenesis. So again, it increases the blood sugar level, it causes compensatory hyperinsulinemia. Compensatory hyperinsulinemia again potentiates the action of LH, causes inhibition of the sex hormone binding globulin, which increases the circulatory and ovarian androgens, and which leads to all sort of abnormality. So if we can take care of hyperinsulinemia, if we can take care of LH, raised LH, most of the problem are solved, which will lead to a decreased androgenic environment in the follicle, as well as the bring down the circulatory androgens, which will correct the HPO axis, the GnRH pulse, and gradually it will regularize the hormonal profile in PCOS. Thank you.